Thank you for joining me today. My name is Catherine Murphy. It's my pleasure to present to you, on behalf of Ansell Australia, a presentation regarding improving the safety and quality of Australian healthcare. Before I make this presentation, I'd like please to draw your attention to the following disclaimer. Please note especially that from time to time I'm a casual consultant to multiple members of the medical industry and device manufacturers in Australia and internationally. For today's presentation, I'm working in the capacity as a consultant to Ansell Australia. As well, during the course of developing the materials for today's presentation and for its companion publication, EPIC 1, I've drawn upon the knowledge and thoughts of several key opinion leaders, and I'd especially like to acknowledge and thank them at this point. The staff of the Australian Commission on Safety and Quality in Healthcare, who've been instrumental in developing our new national standards, and in particular Margaret Banks, who was the Acting Senior Operations Manager and oversaw much of the development of these national standards, and both Marilyn Cruikshank and Sue Gregg from the National Healthcare Associated Infection Prevention Program. I'm also very grateful to Everin Barkle from Ansell Healthcare Australia, and Everin works there as the Marketing Manager for Australia and New Zealand. So we have a number of objectives for today's presentation. Firstly, I'll be talking a little bit about some of the major drivers we have for healthcare reform and for improving safety in the Australian healthcare setting. I'll discuss briefly the intent of the new National Safety and Quality Health Service Standards, and I'll summarise the processes that have been used to date to accredit Australian hospitals and day procedure services. We'll also be listing the individual standards that comprise the full suite, and in particular we'll focus on Standard 3, which is the infection control standard, and it has a lot of application for both infection control professionals and operating room nurses. And then I'll specify some additional sources of information regarding these new national standards. So let's look now very quickly at some of the priorities and policy positions that have been adopted by the national government. And in fact, whilst these new standards were not released until the 1st of January of 2013, if we look back from even July 2008, the federal government gave us a very clear indication of where they wanted Australian healthcare providers to move in terms of infection control. In the publication Reducing Harm to Patients from Healthcare Associated Infection, the Role of Surveillance, the government very clearly articulated a position around many clinical issues of concern and some issues regarding infrastructure. This almost white paper document was followed up later in the end of 2010 with the publication of the Australian Guidelines for the Prevention and Control of Infection in Healthcare. Now, those guidelines provide a very broad, overarching framework for hospitals, healthcare settings, and even smaller clinical practices to follow good evidence-based practice to prevent healthcare-associated infection. And more recently, in 2011, the federal government released Antimicrobial Stewardship in Australian hospitals, clearly highlighting the concerns that they and clinicians had regarding increasing antimicrobial resistance in Australia and the decreasing armoury that we have available in terms of antimicrobial agents that are effective. So there was no surprises in the content of the standards, and in fact the standards very well reflect the intent of each of these three previous documents. So one of the other drivers that's been happening in Australia, and you can see from this publication, the Sydney Morning Herald, an article published back in November 2011, we can see that governments at state level certainly, and more recently at a national level, have increasingly been publicising the evidence and the incidence of infections in their home states. So in this case, we have data from New South Wales that reports, for example, 0.36 cases of healthcare associated infection in the HealthScope private healthcare sector per 10,000 patient days, whereas in the New South Wales public sector we saw a rate of 1.2 cases of infection per 10,000 days. Now, in this type of rate is not particularly meaningful for the general public, although the politicians would have us believe that they collect this data for purposes of transparency and also purposes of improvement. However, I'd argue that we need to certainly provide this type of data for our patients so that they can make informed decisions and that they can step up and take their role in preventing infection, but we need to present this data to them in such a way that it's meaningful and that it makes sense to them and it enables them to be empowered to assert some degree of influence over the care that they are either receiving or demanding within both the public and private sector within Australia. So just think about this increasing public release of data as one of the major drivers for improved standards both in infection control and several other areas of quality of care. If we look in much more detail here, you'll note that late in 2011 the federal government released the myhospitals.gov.au website, and in that website it enables citizens of Australia and people anywhere in the world actually with web access to type in the postcode or the location of any public Australian hospital, and from that website determine specific infection rates including the Staphylococcus aureus bacteremia rate, and also to look at hand hygiene compliance within that organisation. The data is presented according to a national benchmark in that little graphic, looks like an odometer, and it again gives a fairly meaningless rate. It gives a specific 6-month time period, and so far the timing has been fairly relevant. The data is not too old by the time it gets published, but again, I'd contest that for a general member of the public to read that there were 16 cases of SAB or Staph aureus bacteremia during 271,000 plus days of patient care, it's a very meaningless way of presenting the data. But it does enable a patient to make some comparisons between specific hospitals, and over time perhaps as these types of infection rates become more popular and there are more of them published, patients may have a better understanding. But clearly the government is looking for more transparency, and we can expect to see Australian patients having a greater role in their own care. So that's where we stand so far from a government public policy position, one of the other drivers being patient education. But what about from an economic point of view? And this is a very thoughtful article, summarised here and published by Stephen Duckett, one of the Australian experts, where Duckett talks about some of the incentives for providing good quality hospital care. And in this, he raises, not for the first time, but an early indicator for sure, about the concept of non-payment for non-performance. So that is, where a particular hospital is not performing to a predetermined level or is perhaps performing lower than the national average, then should the government consider some sort of penalty? The reverse being, of course, that those hospitals that perform well and reach target or exceed target or perform beyond the national average perhaps should be paid for performance. So it's both sides of the coin here. But what was particularly telling in this article from Duckett, published in the Medical Journal of Australia, was that his suggestion that the work of the Australian Commission on Safety and Quality in Healthcare be used by Australian leaders to develop their own short list of conditions that should be linked to quality of care, and that that list should only include conditions where responsibility for the adverse event can be clearly attributed to the hospital and its staff. perhaps because that hospital and or its staff failed to implement the Commission's new national safety and quality standards. So the implications of this recommendation from Stephen Duckett could be that where a patient comes into a hospital and is free of infection, and then through some clear attribution or some failure to deliver healthcare in a particular way, or some intervention that was not done properly, a patient developed an infection, then perhaps there would be some liability. So again, a major driver, both an incentive to follow these standards from a potentially litigious point of view, but also an incentive from non-payment for non-performance. So an early indication that performance in Australian hospitals will be linked ultimately to payment. And there have been some other state-based examples of this, I believe. So there were responses to Duckett's paper, and this one from Queensland, where they talk about just the controversial nature of this, but how in Queensland activity-based funding is being applied using a purchasing framework, and its aim is to improve the safety and quality of healthcare in Queensland, and that Queensland has in fact been one of the first Australian states to apply a financial lever to incentivise improved patient outcomes. So that financial lever can either be an incentive or it can be a disincentive. So good examples, I think, of the future of Australian healthcare and how all of these new standards, drivers, public policy, how they will all interplay, and in fact how these new national standards for safety and quality are so fundamental to the future of Australian healthcare. So again, here are the major drivers listed: public disclosure and perception, activity-based funding, and funding that's based on outcome with either payment or non-payment according to performance. So let's shift gears a little now and look more closely at these new standards. There are, as you can see from this list, 10 new standards, and they address both areas of governance and clinical areas. So they also include a standard around patient communication and involvement of patients, their carers and their family. So what was the intent of these standards? Well, the intent of these standards were that they would very seriously drive new improved safety and quality systems across Australia, and that they would be used to not only drive the implementation but also to be fundamental for those systems to be operational and for them to be very clear, to be standardised for all Australian healthcare providers to know what was expected of them, and conversely for patients within the Australian healthcare setting to be very aware of the obligations of healthcare providers and what they are committed to providing to healthcare consumers. So the overall intent was that these new national safety and quality healthcare standards would improve the quality of Australian healthcare service provision, defining that new level of care that consumers can expect, and that those improvements and better expectation would come from the development and ongoing maintenance of stronger, more meaningful partnerships between managers, clinicians, and patients and carers. So it's a very new involvement and a focus on patients and carers and their critical involvement as part of the partnerships. And all of this really stemmed from the national health reform that occurred in 2011, and as part of that reform, the role of the Australian Commission on Safety and Quality in Healthcare, affectionately known as the Commission, was revised, and one of the responsibilities given by the national government to the Commission was that it deemed the Commission to now be responsible for the process of approving a series of accrediting agencies who would be responsible for assessing healthcare service organisations against the new national safety and quality standards, and any other standards that were specifically applied in each of the states or territories by their regulatory agency, typically the ministries or departments of health. So under that scheme and the new Healthcare Reform Act of 2011, the Commission has to oversee both the application processes, the assessment criteria, and any of the requirements for accrediting agencies. Now, there have always been multiple accrediting agencies in Australia. However, the market really has been dominated by the Australian Council on Healthcare Standards, or ACHS, and prior to the new national standards, typically ACHS would be responsible for accrediting at least 75% of all the hospital beds in Australia, and that's certainly been the case for perhaps the past decade. However, the remaining 25% of hospital beds that were unaccredited were able to be unaccredited because the whole accreditation process was always voluntary, meaning that an organisation was not mandated to be accredited. And that is a major change under the new standards, because under these new standards, every private health service and every public hospital, acute care hospital, must undergo accreditation against the national standards. And those standards will now have several agencies that will be trained and use the standards as a tool for accreditation, and those accrediting agencies will be approved. They'll be expected to consistently use the accreditation standards, and they must report any aberrations from the standards both to the Commission and perhaps even to the regulators. And it can be up to the regulators to determine what type of action is undertaken. So the Commission really has a very specific role, or several specific functions under that role, and that is they had to formulate the national scheme, and that scheme was to provide accreditation for organisations that provide healthcare, and that scheme had to relate to healthcare safety and quality. And they did that by developing the new model, and it also includes a requirement that accrediting agencies have to be approved by the Commission. So an accrediting agency must meet a series of predetermined criteria, including training, and there are certain stipulations around where and when those accrediting agencies can apply these national standards. For example, they cannot use the national standards to accredit hospitals or healthcare providers externally to Australia. So let's look now at some of these responsibilities and roles of the specific accrediting agencies. Well, they must always use the national standards in their entirety and in the way that they've been designed to be used, and irrespective of which accrediting agency, their use of the standards will be uniform. So it's very much a standardisation process of the standards. Those standards must be used without modification, and they must use the agreed assessment processes. We'll be talking about them, and they're to be used without modification. So the standards map against other safety and quality standards that can be used for assessment. So they may be specific to a state or a territory. And once a hospital reaches their accreditation and is through the process, then they are awarded a certificate from their respective accrediting agency, and that certificate indicates that they've passed the accreditation period. From time to time, a regulator, so a Ministry of Health or a State Department of Health, may stipulate other standards against which the healthcare provider must be assessed, and that could change over the course of the rollout of these new national standards. Once an accrediting agency accredits a hospital or actually fails a hospital for accreditation, then they must provide that accreditation information to the health service organisation, so the hospital or the day procedural service centre. They must provide that information to the regulator and also to the Commission. And they must also, as I said before, seek written approval from the Commission if they have an intention to use the Australian standards against health services outside of Australia, so for commercial reasons. So we'll look now very generally at the 10 different standards. The first two standards are non-clinical, and they actually are standards alone and in their entirety, but they are also embedded in each of the following 8 clinical standards. And they are governance, so good systems for governance, for safety and quality in every health service organisation. And second, the underpinning of partnerships. We talked about the partnerships between management, clinicians and managers, leadership within organisations, patients, consumers and carers. So the third standard is the one that we're most familiar with and which is of most concern today for us, and that's Standard 3, the prevention and control of healthcare-associated infections. The remaining clinical issues addressed in the subsequent 7 standards are medication safety, patient identification and procedure matching, clinical handover, blood and blood products, prevention and management of pressure injuries, recognition and response to clinical deterioration in the acute care setting, and prevention of falls and harm from falls. So very comprehensive suite of standards addressing those areas of patient safety that we know are largely preventable and those areas that have an impact on a large number of patients. There are also the 10 areas where we know that there's a big gap between current situation and perhaps best practice outcome. So there's lots of room for improvement. We also know that the improvement strategies that have been recommended from leading experts both domestically and internationally are strategies that are based on evidence, and they are clearly achievable and have been achieved in many settings. So these standards, new national standards, are incredibly important, and in fact they will impact every hospital. Every licensed and regulated healthcare organisation's delivery of care is now impacted by these standards. The standards are mandatory and they are also non-negotiable. In their most simple form, they represent the reasonable quality and safety of healthcare that hospitals and healthcare organisations must deliver to any Australian. There was, I believe, a potential for these standards to be confusing and perhaps confronting to healthcare providers and consumers in their early months after their introduction in January of 2013. However, over time, through the provision of very detailed information and more public discussion and discussion in the scientific and academic literature and those relevant circles, perhaps it's fair to say that that confusion is reducing, and healthcare providers and consumers are becoming much more comfortable with these standards. And again, that will improve hopefully over time, the longer that the standards are in place. So the standards, importantly, make no specific recommendations regarding any product use, but they do offer several opportunities for product manufacturers and others to support the prescribed practices and procedures, so whether that be through the provision of education or through the development of new technologies. So we can look forward, I think, to much more from medical device manufacturers and their involvement. So the standards are structured in a very uniform way. Each standard is designed to apply to either the hospital setting or to the day procedural service setting. And there's really not much difference between the requirements in each of those settings. In fact, it's very, very minimal, and we'll talk about what that minimal changes are. But each of the standards has a set of core actions which actually comprise the majority of the standards. And under those core actions, if we look at Standard 3 for the hospital-based standard, we'll see that there are 39 of those core actions. And each core action is critical for safety and quality. A hospital or a day procedural service must meet every one of those core actions if they're to pass accreditation. Whereas in contrast, there are a very few developmental actions. And those developmental actions are not mandatory. They're not yet considered critical for safety and quality, but rather they are the areas about which organisations can, if they choose to, focus on to improve patient care. And activity may be required, but it does not have to be met fully. And that's simply an issue of probably evolving evidence. If we look now at these hospitals, you will see that there are 39 core actions. As we've suggested, there are many of them. And if you look at the developmental actions in hospitals, there are just 2. We'll look at them later. So, 20 times more core actions than there are developmental actions for hospitals. And if we look now at day procedural services, we'll see that there are 38 core actions, so just 1 less than the hospitals. And in the developmental actions, there is just 1 more developmental action in day procedure services than for the hospital setting. So there are, as I said, in each of the standards, a set of non-clinical actions, and those non-clinical actions are uniform, and what they include are things like evidence of policies, evidence of protocols and procedures, and evidence that those policies, protocols and procedures are regularly reviewed and updated. So that's a very important from a directive point of view in terms of governance, that those policies, protocols and procedures exist. There's also a requirement that organisations provide training, and not only that they provide training, but that their workforce actually actively participates in that education and training, sometimes on a regular basis. There are also across the board recommendations regarding the patient's clinical record and what types of information need to be recorded in that record and the level of detail that's required. There are also requirements relating to particular data that needs to be collected, and that data can be collected for auditing purposes or for review purposes, perhaps even for research purposes. So very clearly clinical areas and non-clinical areas. So let's look at the levels of performance that are required from a hospital to meet the standard. The hospital has to actually demonstrate these 10 or so points. They have to show that there are policies, procedures and protocols in use, that they have systems for monitoring and reporting against the standards and monitoring perhaps compliance with procedures, policies or their protocols, and that they have very clear systems of reporting, and that once those reports are made and that monitoring is undertaken, that action is always taken to improve. So part of this ongoing cycle of improvement. They must also show that training occurs and is provided regularly and taken up. That they have regular reviews in the hospital, including risk assessments, so that where a risk can be considered to exist, it can be addressed before the risk actually becomes a problem. They must show in their organisation that best practice is based on evidence or is consistent with international best practice where that evidence is lacking. There's an emphasis here for the first time probably in Australian safety and quality settings for some reflection around the processes and systems that are in place. And there's also a big emphasis on communication and that relevant equipment is available, serviced, maintained, cleaned and managed so that it's available to obfuscate some of those risks. So there's some of the things that underpin the standards. So how in fact is the assessment done? Well, when a hospital is assessed against each of the criteria, they have the opportunity to be assessed against a 3-point rating scale. And that 3-point rating scale in the middle has satisfactorily met, which means that all of those actions that are required have been achieved. And in that case, the hospital will pass their accreditation. If, however, the hospital has not met some of the required actions, then they will get a not met on the 3-point scale, and that is enough for them not to pass accreditation. However, some hospitals will on the other end of the scale, absolutely exceed the satisfactorily met level, and they will meet the standard or its criteria with merit, which means that it's good quality and a higher level of achievement, and it requires and is capable of getting that extra acknowledgement. So in the event that a hospital fails to meet some of its obligations and doesn't pass accreditation, what can happen in those circumstances? Well, first of all, once the Commission is informed of the outcome of the accreditation and the regulator, so the Ministry of Health or the State Health Department, becomes aware, then the first thing that they would do, and it's a reasonable step, is that they would confirm that the concerns that are being raised in the non-accreditation status are actually genuine. So they would ask who identified these concerns and then perhaps verify the rating that's been applied to those concerns. They would then go on and identify the scope, the impact and the spread of the issue. So for example, if there were an issue around sterilisation or disinfection, then they may, from a public health point of view, want to know the actual extent of that problem and how extensive it is and what types of numbers, what types of patients have been involved in that type of failure to comply with that element of the standard. The agency responding will also want to review what strategies are being put in place and implemented to obfuscate against these concerns, and then there would be a time frame that would be developed and accepted showing that the risk will be mitigated against within a set period. So any of that action from the accrediting agency can be followed up, as I said, by either a response from a regulator or from the department, any department that's been involved. And how the regulator may respond, so the state Ministry of Health or state-based territory or even the federal departments of health could respond in the most extreme measures by some of these ways. They may restrict specific practices being undertaken until an organisation is able to demonstrate that they meet the standard. They may suspend particular services until any of the concerns are resolved, or if in fact the issue relates to something which is addressed in the licensing conditions or funding conditions, and they may be affected for a particular organisation. So if there's a significant public health danger, for example, or an organisation may be suspended or some of their services suspended, or in the very extreme measures they may have their licence or their funding withdrawn, and that would be clearly in those areas where breaches are of most concern. So other positive ways that the department can respond, not in a remediatory way, but not in a punitive way rather, but in a way to help remediation, is that the department or the ministry may actually also be the agency that provides advice or information and even some strategies to address these concerns, or hospitals and organisations may work with each other or work in their close collectives to try and address concerns. And networking between health services is one of the strategies that's been suggested as having a good opportunity or a good potential for quality improvement. The other way that the department or the ministries may respond is by providing support to the organisation to assist them to meet the requirements of the standards. So if a risk is identified by a surveyor, then that surveyor will make a judgment about how significant that risk is in terms of harm that can potentially occur to the patient. So the surveyor would then notify both the health service organisation and their accrediting agency that a significant issue has been identified, and the surveyors and the agency will negotiate with the health service organisation to develop and implement a plan of action and a time frame in which those issues can be remedied. The relevant regulator will become involved, as we've talked about, and as soon as practical action will be taken, usually within 1 working day. So some of the areas and the list that's been provided by the Safety and Quality Commission around areas that they consider to be significant and risk burdensome follow, and some of them may be surprising to you in terms of their severity. So let's look now. So under Standard 3, what are some of the risks? Well, if there's no evidence or limited evidence of hand hygiene across the organisation, that's considered to be a fairly substantial risk. If single-use items are being reused, if there are multiple instances where aseptic technique is being breached, or multiple incidences where standard precautions and transmission-based precautions are not being practiced, or where there's a failure to decontaminate and properly reprocess medical devices. So the impact of those areas of non-compliance are, of course, that there's a potential for infections which are otherwise preventable to be transmitted to patients. And a similar thing exists within Standard 8, although it's a far shorter list. The failure to identify risks of pressure injury or infrequent skin inspections. So within these standards, they provided a very tight framework for us and very clear those areas that are of most concern to the government. So we have looked at this slide before, and now I'd like us just to focus very closely on Standard 3 in particular and look at some of the elements that are specific to Standard 3. So let's have an overview of Standard 3, the standard of preventing and controlling healthcare-associated infection. This is what the standard looks like. It was published in mid-October 2012 and I think has had very little revision to it. It was several years in the making and much informed discussion from experts in both the infection prevention field and also in the standard writing field to come up with something which is both usable and importantly will improve the standard of care. So the Commission recently presented on how they see the standards generally and in particular how they see Standard 3. So they said that the standards will direct health services as to how to provide good governance, and that includes in Standard 3, and that good governance structure is well outlined in Standard 1. That Standard 2 emphasises the importance of partnerships, and those partnerships include those between clinicians, managers and consumers. Standard 3 is an important standard because, unlike some of the others, it must be included in every mid-cycle review. So that means that it is a critical standard and that every 2 years accredited organisations will be accredited against it, and in some cases that frequency of accreditation, depending on the requirements, will mean that organisations are accredited against it annually. So Standard 3 does require patients and carers to be much more involved, monitoring, they're being encouraged to speak up. The standard acknowledges that the clinical workforce will need support and that for one of the first times, not the first time, but certainly it is new for non-clinical workforce members also to be involved. Standard 3 acknowledges that health service managers have a key role in managing performance, in modelling behaviours and also in making sure that in the planning and review they're integrating governance into all of their organisations. Because the Commission believes that at least half of all healthcare associated infections are considered preventable. Now that's actually a contentious issue because some experts will suggest that up to 100% of some specific healthcare associated infections or HAIs are preventable. And there's been much work, for example, from the United States on central line associated bloodstream infections or CLABSIs, where we have clear evidence that they are entirely preventable and that elimination of these infections can occur for an extended period of time. So sustainable elimination. So you'll see that the benefits of Standard 3 as presented here by Dr. Cruikshank at a recent conference in Sydney at the end of 2012 said that the benefits were that they would reduce the risk of patient harm and death, clarify roles, accountabilities and responsibilities, improve information, facilitate antimicrobial stewardship, and also assist in tracking of invasive and reusable devices, as well as increasing a focus on specific evidence-based strategies for infection prevention. And we've not had that before. Can only be a good thing for the Australian healthcare setting. So the clinical areas that are prioritised under Standard 3 according to the Commission include when a patient's admitted, how they're received, how they're transferred, so that whole concept of early identification of infection risk, following through into how the patient is placed, their bed management, their isolation. Hand hygiene is critical. It always has been, it always will be probably, and so it's not surprising to see it given priority under Standard 3. Aseptic technique is recognised as being perhaps underperformed, and so it is given priority, as are the insertion and management of invasive devices, compliance with standard and transmission-based precautions, and then also the prevention of central line-associated bloodstream infections, and vaccination and immunisation for healthcare workers. So these are the clinical areas of priority. And you can see that this standard is actually divided into 6 specific areas. First one looking at governance, including systems for communication. Second one around control and prevention strategies. Third one, management of positive patients who are either infected or colonised. Fourth area being antimicrobial stewardship. Fifth, cleaning, disinfection, sterilisation. And sixth, communication with patients, carers and consumers. So 1 and 6, as I said before, are actually involved in every standard. So really it's just these 4 specific clinical areas that are of great concern to us. So when we look at governance systems, types of things are that there are systems of governance in place, that those governance measures include surveillance, developing systems for reporting, investigating and analysing healthcare associated infections, and aligning that with an organisation's risk management strategy. Also undertaking relevant quality improvement activities to reduce those healthcare associated infections. So what are some of the other strategies that are used? Having a hand hygiene program consistent with the national initiatives, making sure that there is a workforce immunisation program, that there is collaboration with occupational health and safety programs within an organisation, and that care and management, insertion and removal of invasive devices is done according to the guideline document published back in 2010, late 2010. And that those policies and protocols for invasive devices are regularly enforced at a local level, and that aseptic technique underpins all of those clinical procedures, which we know it should. So an emphasis on that. So then what about managing patients known to be infected or colonised? Well, then there's an emphasis on standard precautions and transmission-based precautions where they apply. The importance of assessing a patient and their need for placement based on the risks that they may demonstrate or may hold, and then developing protocols and implementing protocols for admission, receipt and transfer of patients with such an infection. There's also a requirement under antimicrobial stewardship that hospitals develop, implement and regularly review antimicrobial stewardship systems within their organisations. Under cleaning, disinfection, sterilisation, there have to be systems that have been developed, integrated, implemented to maintain a clean and hygienic environment for patients. So that would be both from physical cleaning to quality of air and all of those other sorts of measures. So regular cleaning of the environment plus reprocessing of reusable equipment, and as I said, management of air. Certainly reprocessing is there under 3.16, and that reprocessing is always in accordance with manufacturers' instructions. Also implementing systems to enable the identification of patients on whom reusable medical devices have been used. So an accountability coming in here so that in the event of there being a breach, I guess there's an easier way now to do look-backs and investigations and assessment of risk. Also ensuring that the workforce who are involved in decontaminating reusable devices are competently trained in that process, because as you know, reusable medical devices and equipment is an area of full of opportunity for risk and for problems. So the 6th area there is communication with patients, and so hospitals are being encouraged to develop or to implement consumer-specific information on how to manage and reduce healthcare-associated infections, and to make sure that that information is available at the point of care. And I think that this will be an area of great innovation and development over time. So we'll look very quickly now at the specific clinical measures that the Commission will consider important under Standard 3, and which it has given a clear intention of using to assess the impact of Standard 3 in fact. So rather than looking at specific accreditation results or proportion of hospitals that pass accreditation, first round, second round, whatever it is, they've given some clinical measures, and they are the proportion of observations compliant with the 5 moments of hand hygiene. So the Commission is clearly targeting an improvement in hand hygiene as part of their measure to assess the impact of these standards. They will be looking at the percentage and increased number of healthcare professionals, staff, who complete their available online modules in hand hygiene and infection control, and they'll also be reporting against the healthcare associated Staph aureus bacteremia rate, which will be described per 1,000 patient days. And similarly, they'll be looking at the healthcare associated infection Clostridium difficile rate against per 1,000 patient days. So some good challenges there from a governance point of view, but also some challenges from a fairly tricky microbiological and pharmacological position. So we'll look now very quickly on the possible impact of these standards on healthcare organisations, and it's very early days, so we have nothing to substantiate these, but the intention and the hope is that these standards will revolutionise delivery of healthcare by clearly defining the priorities, by helping establish formal systems and accountabilities, increasing the ways in which the government is involved in influencing healthcare and having formal lines for that to happen. As we suggested in the beginning of the presentation, it's likely to be a link between performance and payment, and also these standards clearly mandate the active involvement of patients, their families and their carers where they exist. So how are hospitals' specific infection prevention programs impacted? It's likely that these standards are forcing infection preventionists to start focusing on those and investing in those areas which are seen as government priorities, and in some hospitals and organisations they may not align with local priorities depending on the geographic area, what's happening in terms of outbreaks, what the service delivery mix looks like in a particular organisation, and other factors. So it could be a malalignment there. There's potentially opportunity for confusion and even some conflict between different requirements of different states and territories versus these national standards, but over time it's expected that those requirements will be in alignment. Standardisation will be important, so that will have professional implications in terms of support for the infection prevention profession. There is also likely to be a inability of local programs to be able to respond and be nimble to and flexible in the ways that they respond to emerging issues and perhaps even outbreak scenarios. So the impact of a significant outbreak against these standards and how that will play out is as yet unreported, but some clinicians are reporting just additional requirements that leave them with very few resources that can be expended on outbreaks. But in fact, that's not a new situation. It probably has just come to the head. The other thing is that these standards actually assume that there's initially a very high level of capacity and engagement and investment in these standards from infection prevention staff, and certainly we hope that that's the case. If not, it needs to become the case very quickly. But there are still some unanswered questions that we think are worth contemplating, and first question is, how do these standards actually differ from some of the previous initiatives that they replace? How will we know whether or not these standards have had a positive impact beyond those few outcome measures that we identified a few slides ago as being the Commission's way of assessing their impact. We're not quite sure yet how we can maximise the support and from administrators and management, senior management, and we're not quite sure how we can actually maximise clinician compliance. But those two things I think will become clearer the longer that the standards are in place. And the other important thing is when we think about the 8 clinical areas, so medication errors, handovers, blood products, patient identification and the like, prevention of pressure injuries, when we think about those multiple clinical foci, it makes us realise that infection prevention has to really work hard and promote itself well to remain at the forefront of these standards, because in fact healthcare workers have a lot of information to take on in terms of quality improvement with these other clinical foci as some of the other clinical standards. So infection prevention is one of 8 other areas, and we must be clever and innovative in the ways that we promote infection prevention. So I'll close by summarising and just saying that this is clearly a time of major reform of safety and quality within Australia. It's unprecedented, but it is somewhat similar to international approaches, and there's just very recent evidence from the United States about some of that international activity with outcome different to that expected by the US government. So we'll watch this space with great interest, I think, in Australia. The other important point is that all clinicians, irrespective of your specific ward or departmental setting, I believe have an obligation to understand and comply with those relevant sections of the standards that apply in your unit, and there are some that will very specifically apply only in your unit, and that's particularly the case for operating room nurses. So we do have an obligation to understand and comply with these standards and to remain current with them as they evolve and they may change. And in general, it's my personal belief, and I think consistent with the government intention, that as a result of these standards, Australian healthcare will become much more transparent, which will be good. It will enable us to have some of these very crucial conversations and to receive input and ideas from consumers of health for whom we exist and for whom we serve in the delivery of patient care. So if you would like any additional resources, there are plenty. This is the general website of the National Safety and Quality Commission, and their page specific to the health service standards. So if you go to www.safetyandquality.gov.au and you search around there, you will certainly find information on accreditation and on the standards generally. And similarly, within that site there is also additional information on healthcare associated infections specifically and Standard 3. So I hope that this has been an informative session for you, of use, and has helped you understand the standards better. In the event that I can ever be of help, please do feel free to contact me through any of these means, and if you would like to know more of our views on the standards and other aspects of infection control, then please do feel free to follow us on Facebook at that address, or through our Twitter account, where occasionally we'll tweet information that we think is critical. So thank you for your attention, and I look forward to being involved with you in the next session of EPIC number 2. Thank you and have a great day.